We have a patient of optic neuritis at our hand. How can we go about and clinically examine and deduce that this particular patient who is suffering from a chronic vision loss is a patient of optic neuritis? Now, there are multiple methods by which we can do it. Is we can start the management of such patients right from the history taking. The history would conclude that the patient is suffering from a chronic vision loss, particularly. Again, it is going to be a painless kind of a vision loss that is demonstrated in these patients of optic neuritis particularly. And once you have deduced that this is a patient who is suffering from a chronic vision loss, which is of a painless kind, you're going to demonstrate whether the patient is suffering from some sort of a systemic ailment or not. So concluding or deducing that the patient is suffering from some sort of a systemic ailment, you would start off with different examinations, even if it is an undiagnosed case of multiple sclerosis, for instance, or diabetic retinopathy. All of these are basically some of the manifestations that can occur. It can be a case of Lyme's disease, for instance. So investigating all of these systemic infections in these individuals or these autoimmune diseases in an individual is again the mainstay over here. The workup is again quite needed whenever you want to conduct or whenever you want to get to the final diagnosis in these patients. It's very important that you perform this initial workup in these patients in a particular way. So you're going to perform and you're going to start off with the initial investigations in these individuals, the blood tests that are required, the ANCA bodies, the p-ANCA that is required for the demonstration of the autoimmune diseases is again very important and the mainstay over here. So you are basically going to relate the systemic ailments to the ocular manifestations in a person and then the neurological manifestations in a person. This is basically the complete workup that is done by a neuro-ophthalmologist whenever you refer a patient to be suffering and you're just basically indicating, or you have basically done, or you are basically working up a differential diagnosis of optic neuritis and moving on to the final conclusive diagnosis in a patient over here. So knowing the epidemiology, the prevalence, the incidences are again very important. We are particularly going to discuss all of this in this third section. We're going to focus on the clinical features of optic neuritis as well. So there is this particular clinical picture that is associated with optic neuritis, the presenting complaints, the history. There's a typical picture that is associated with optic neuritis, and one should know how to diagnose a case whenever he or she sees a particular case of optic neuritis. Then we have an atypical optic neuritis, and what are the features or the symptoms that are associated with this atypical kind of optic neuritis, that will also be discussed over here in this section. So particularly, we are focusing on optic neuritis over here. One should know that any inflammatory changes that are occurring at the level of the optic nerve, we have basically categorized the optic nerve into the bulbar portion, and then we have the retrobulbar portion. The bulbar portion is basically situated inside the globe, and then we have the retrobulbar portion that is situated posteriorly whenever the nerve leaves the optic globe. Then we have the atypical optic neuritis. We have the treatments that will be discussed over here mainly. And then how do you associate optic neuritis with multiple sclerosis? So again, it's very important that in almost 60% of the cases of optic neuritis are usually associated with multiple sclerosis. So it's one of the major cause that we usually see in the patients. So one should know how to relate this optic neuritis with multiple sclerosis in the patients. The incidence is almost 1 to 5 per 100,000 per year. Highest incidence is noted down in the Caucasians. In the countries with high latitudes, then we have springtime is somehow associated with the development of an optic neuritis in the individuals. The age group that is usually associated with is almost 20 to 50 years is the normal age group that is associated with it. Usually the female gender is more prone to the development of optic neuritis. So these are some of the risk factors or some of the factors that make the person more prone to the development of optic neuritis. So one should know how to relate these factors whenever you see a case of optic neuritis in an individual. The clinical features would include subacute clinical features, or there is basically a monocular vision loss that is noted down in the individual. So it's somewhat a chronic kind of a vision loss that is usually seen in the individuals of optic neuritis. Sometimes it's usually painless, but sometimes the extraocular movements that are involved along with the optic neuritis, they're quite painful. It's usually a case of RAPD. We usually demonstrate dyschromatopsias in the individual. There is a decreased contrast sensitivity that would be quite evidently demonstrable whenever we ask the person to read out the numbers or the digits on the Ishihara's charts. We have the visual field deficits that are quite visibly seen in the individual. The signs and symptoms would include the atypical signs on one hand, and then we'll contrast them with the typical signs and symptoms of optic neuritis. So the unusual tempo of the onset is very important. We usually observe a chronic kind of an onset that is quite demonstrable in these patients of optic neuritis. There is an absence of pain usually. It's a painless chronic vision loss that is associated. The extraocular movements are usually quite painful in these individuals. Comorbidities such as multiple sclerosis, Lyme's disease, trauma, all of this has to be identified. If you find these features while you're taking the history from the patient, you have to highlight these features because they are highly associated with the development of optic neuritis in a patient. Even the risk factors, if they're found, when you're taking the history, you have to highlight them, which are basically making the conclusive diagnosis more easier in the patient. The atypical signs would include the progressive decline in the vision. And then there is going to be a 2/52 decline. If it is not treated, it is a severe visual field defect in an individual. Severe hemorrhagic disc edema is observed in these individuals who are suffering from the atypical optic neuritis. Uveitis, wireitis, retinitis, choroiditis, all of these are sometimes associated features. Persistent on-sheath enhancement on MRI. So all of these are basically the atypical signs, but they can be sometimes demonstrated in a lot of individuals, but we have to look for the typical signs in a typical patient of optic neuritis over here. On the other hand, we have the atypical optic neuritis. The atypical optic neuritis would include the response to the steroids. So usually the atypical optic neuritis would respond to the steroids whenever we treat these patients with steroids. The vision falls with taper, and it requires investigation to know the causative factors for the development of the atypical neuritis in the individuals. So all of these features, we have to note down that usually the optic neuritis or the inflammatory changes that are taking place at the optic nerve, they do not usually respond to the steroidal treatment. But in this case of atypical optic neuritis, we'd see that they're responsive to the steroidal treatment in these individuals. The laboratory investigations would include the complete blood picture, the ESRs, the ANAs, just to highlight the autoimmune processes that are taking place in the individual. The Lyme's disease is going to be taken for. The TB skin test, the Bartonella test is sometimes demonstrated in these individuals as well. So all of these autoimmune diseases, they have to be demonstrated in these individuals just to associate them whether the patient is suffering from some sort of multiple sclerosis or this is a picture of an atypical optic neuritis that is seen in these individuals. Chest x-rays are sometimes performed in a lot of individuals just to exclude tuberculosis in the individuals. We also sometimes consider the lumbar punctures, and they are basically going to exclude any cases of meningitis, which can be either of a bacterial origin or either it can be of a viral origin in these individuals. Make sure the MRI images of the optic nerve and the orbits are taken in the individuals. The visual fields are tested for any central scotomas and then the paracentral scotomas if they're found in the visual field. Altitudinal defects, if they're found, they have to be highlighted in these individuals as well. So over here in this section, we just summarize this condition, which is quite important. Working as a neuro-ophthalmologist, one should know how to deal with these cases of optic neuritis and how to treat them appropriately. So that is the end of this section. Thank you for watching sqadia.com.